بسم الله الرحمن الرحيم
قالوا سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم.
بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه أجمعين. This is the third part of your lecture, Regenerative or Reconstructive Osseous Surgery, presented by Professor Mona Yehia. Changes in the root surface wall of periodontal pockets, example, degeneration of remnants of charpus fibers, accumulation of bacteria and their products, and disintegration of the cementum and dentin, interfere with new attachments. However, these obstacles to new attachments can be eliminated by thorough root planing. Several substances have been used in attempts to better condition the root surface for attachment of new connective tissue fibers. These include citric acid, fibronectin, and tetracycline. The following actions of citric acid have been reported. Number 1, accelerated healing and new cementum formation, which occur after surgical detachment of the gingival tissues and demineralization of the root surface by means of citric acid. The topically applied citric acid produces a 4 mm deep demineralized zone with exposed collagen fibers on root planed surfaces only, not on periodontally diseased non-planed root surfaces. The citric acid application not only removes the smear layer of microcrystalline debris left after root planing, exposing the dentinal tubules, but also makes the tubules wider and with a funnel-shaped orifices to facilitate reattachment. Number 4, the citric acid has also been shown to eliminate endotoxins and bacteria from the diseased root surface. An early fibrin linkage to collagen fibers exposed by the citric acid treatment may prevent the epithelium from migrating over the treated roots. The techniques that are used for citric acid application is as follows. Number 1, we have to raise a mucoperiosteal flap. Number 2, thoroughly scale and plane the root surface, removing calculus and diseased cementum. Then we apply a cotton pellet soaked in saturated citric acid pH 1 and leave it for 2 to 5 minutes. Then we remove the cotton pledget and irrigate the root surface profusely with water. We replace the flap and the recommended techniques for citric acid application. We have to notice that this technique has been extensively investigated in animals and humans. Studies in dogs have given encouraging results, especially for the treatment of percussion lesions. However, the results in humans have been contradictory. The use of citric acid has also been recommended in conjunction with coverage of the nuded roots using free gingiva. Fibronectin is the glycoprotein that fibroblasts require to attach to root surfaces. The addition of fibronectin to the root surface may promote new attachment. However, increasing fibronectin above the plasma levels produces no obvious advantages. This material is commercially available in Europe as tissue coal. Tissue coal is a biologic mediator that enhances the tissue response in early phases of wound healing, prevents separation of the flap, favors hemostasis and connective tissue regeneration. Clinical trials have been promising, but further investigations are needed. Number 3, tetracycline is also used as a wound conditioning material. In vitro treatment of dentin with tetracycline increases binding of fibronectin, which in turn stimulates fibroblast attachment and growth while suppressing epithelial cell attachment and migration. It also removes an amorphous surface layer and exposed tubules. In vivo treatment of dentine with tetracycline has not shown favorable results. A human study showed a trend for greater connective tissue attachment after root treatment with tetracycline. We have to notice that tetracycline alone gave better results than when combined with polypeptide growth factors. Growth factors are polypeptide molecules released by cells in the inflamed area that regulate events in wound healing. They can be considered hormones that are not released into the bloodstream. Growth substances regulate connective tissue cell migration and proliferation and synthesis of proteins and other components of the extracellular matrix. These factors are primarily secreted by macrophages, endothelial cells, fibroblasts, and platelets. They include the platelet-derived growth factor, the insulin-like growth factor, basic fibroblast growth factor, transforming growth factors alpha and beta. The enamel matrix proteins, mainly amylogenin, are secreted by Hartwig's epithelial root sheath during tooth development and induce acellular cementum formation. They are believed to favor periodontal regeneration. One enamel matrix protein marked as endogene, obtained from porcine teeth, has been approved by the Food and Drug Administration, FDA. The material is a viscous gel obtained by mixing 1 milliliter of a vehicle solution with the powder and applied with a syringe into the site. Graft materials are categorized by their origins and functions during healing. Categorization by origin includes autografts. This means that the grafted material is obtained from the same person. Or allografts, in which the grafted material is obtained from different persons of the same species. Xenografts means that the grafted material is obtained from other species. They are also categorized and evaluated based on their osteogenic, osteoinductive, or osteoconductive potential. We have to know those terminologies. Osteogenesis means the formation or development of new bone by cells contained in the graft. Osteoinduction is a chemical process by which molecules contained in the graft as bone morphogenetic proteins convert the neighboring cells into osteoblasts. Or osteoconduction, this is a physical effect by which the matrix of the graft forms a scaffold that favors outside cells to penetrate the graft and form new. The considerations that cover the selection of a graft material have been defined as follows: biologic acceptability, predictability, clinical feasibility, minimal operative hazards, minimal post-operative sequelae, and patient acceptance. All grafting techniques require pre-surgical scaling, occlusal adjustment as needed, and exposure of the defect with a full thickness flap. The flap technique best suited for grafting purposes is the papilla preservation flap because it provides complete coverage of the interdental area after suturing. The use of antibiotics after the procedures is generally recommended. Autogenous bone graft, bone from intraoral sites. Bone grafts from the same patient are used for the reconstruction of bone defects produced by periodontal disease. The sources of autogenous bone include bone from healing extraction wounds, from edentulous ridges, bone terrifying within the jaw without damaging the roots, a newly formed bone in wounds specially created for the purpose, or bone removed during osteoplasty. And this slide shows some of the instruments that are used for the removal of autogenous bone. In the upper left, we have a bone filter in line with a surgical evacuation tip. This sterilizable filter system can be dismantled for cleaning and is available for German Science incorporations. In the right, we have a terfine drills. 3 terfine drills for use in the handpiece. The outside diameter is 2.3 mm, in the center 2.8 mm, then 5 mm. In the right, you can see the working end of the manual terfine drill with dispensing attachment. The outside diameter here is 5 mm. The lower picture shows the hand terfine. This terfine is engraved every 1/4 inch or 5 mm, so that the surgeon can always ascertain how deep the tip has penetrated. Reducing the solid core of bone removed with the terfine to small chips can be difficult. Possibilities include squashing with a forceps or cutting with a scissor or scalpel. In order to obtain autogenous bone with a terfine, the periodontal surgical site usually must be extended beyond the normal limits. It may be necessary to raise a mucoperiosteal flaps in another area of the mouth in order to gain access to an appropriate site to harvest the autologous bone. The transplant should include spongy or less desirable cortical bone. Before transferring the autogenous bone to the periodontal defect, it must be split into tiny chips that do not exceed 1 cubic millimeter. The rongeurs and scissors can accomplish this. In the top left picture, we can see that we can collect a considerable amounts of osseous substance on a sterile filter in the evacuation system when a round burr is used for osteoplasty with copious irrigation using sterile saline. On the right, the bone chips are mixed with blood and placed into the prided defect. This is known as the osseous coagulum and is effective to be used in 2 and 3 wall intrabony defects. In the bottom left, we can see the retromolar area that has been the site for collection of autologous bone or autogenous bone using a 5 mm terfine drill mounted in the contra-angle handpiece. Constant irrigation with sterile saline is mandatory during such procedures. The core of bone must be freed using the drill or an elevator. In the right, we can see the durable Williams probe is used to dislodge the bone, which is reduced to chips in saline solution before implantation. The left picture shows that access in the oral cavity is difficult with this relatively gross instrument or manual terfine. It is indicated almost exclusively for harvesting bone from the edentulous ridge, especially in the tuberosity area. A sagittal incision through the mucosa is made to permit re-entry. In the right, we can see that the adherent soft tissue should be removed from the osseous material before transplantation, and the bone must be reduced to small chips. This is a case representing a 30-year-old female wished to have the space in her upper left quadrant closed by means of a fixed bridge. But a 7 mm infrabony pocket could be probed on the mesial aspect of the tooth number 27. The examination led the practitioner to suspect a multi-wall defect. The treatment plan called for filling this defect with autologous bone. The edentulous area between 2.4 and 2.7 was available as a site for harvesting the transplant material. In the upper left picture, we can see the persistent 7 mm infrabony pocket mesial to the second molar is depicted clinically with a Goldman probe in situ. A 5 mm gingival pocket was also present on the distal aspect of the tooth number 2.4. On the right, the deep pocket mesial to the tooth 2.7 is depicted in the radiograph even more clearly than in the clinical view. The right pictures shows the incisions. Facial and oral flap reflection is necessary in order to perform periodontal treatment on 2.4 and 2.7 with simultaneous harvesting of autogenous bone. The primary incision courses parallel to the alveolar crest in the edentulous area between the two teeth. As the incision approaches the teeth, it becomes a circular incision on both facial and oral aspects. Distal to 2.7, the incisions end as a modified wedge procedures. In the bottom left, we can see the surgical field exposed. Following root planing and debridement of the intrabony pocket, the 3-wall defect mesial to 2.7 and 2 of the 3 donor sites are visible. Instead of a single 5 mm explant, 3 small 2.8 mm pieces were taken without altering the contour of the alveolar ridge. The 3 pieces of bone were further reduced in size before transferring to the defect. To the right, you can see the radiographic view of the terpine drill during bone removal. After transplantation of the bone, bony chips with a maximum size of 1 cubic millimeter are tightly wedged into the 3-wall defect. The crater is completely filled and blood clots fill the donor site. Such sites re-ossify quickly, similar to a minor extraction site. On the bottom, we can see the healing of the site, which can occur optimally if the flap closure is complete and secure. The surgical site should be protected from mechanical trauma by a periodontal dressing, or as in this case, with a tissue adhesive. On the left, we can see the radiographic check of the osseous fill compared to the initial radiograph. 3 months post-operative, we can see that the healing proceeded without complications. Fabrication of the fixed bridge can begin in a few more months after complete consolidation of the site. 7 months post-operative, seating of the bridge. The 4-unit bridge is first seated temporarily. The bridge abutments were prepared for 3/4 crowns with all margins located supragingivally. Interdental hygiene is easy using spiral brushes. The periodontal pocket mesial to the tooth number 2.7 has been eliminated via apical positioning of the gingiva and possible osseous regeneration. On the left, the radiograph reveals that the previous osseous crater has filled with newly regenerated bone. A mixture of bone dust and blood is termed osseous coagulum. The technique uses small particles ground from cortical bone. The sources of the implant material include the lingual ridge on the mandible, exostosis, edentulous ridges, bone removed from osteoplasty or ostectomy, or the lingual surface of the mandible or maxilla at least 5 mm from the roots. The bone is removed with a carbide burr number 6 or number 8 at speeds between 5,000 and 30,000 rotations per minute, placed in a sterile Depin dish or amalgam cloth and used to fill the defects as we saw in the previous. The advantages of osseous coagulum is the ease of obtaining the bone from already exposed surgical sites, and the particle size provides additional surface area for the interaction of cellular and vascular elements. However, its disadvantages are the relatively low predictability and inability to procure an adequate material for large defects, the inability to use aspiration during accumulation of the coagulum, unknown quality and quantity of the bone fragments in the collected material. Therefore, a bone blend was used. To overcome these problems, the so-called bone blend technique has been proposed. The technique uses an autoclaved plastic capsule and vessel. Bone is removed from a predetermined site, triturated in the capsule to a workable plastic like mass, and packed into the defects, like we do in the amalgam. The intraoral cancellous bone marrow transplant is also used as a source of autogenous bone grafts. The cancellous bone can be obtained from the maxillary tuberosity, edentulous area, healing sockets. Bone swaging is technically difficult and its usefulness is limited. The technique requires the existence of an edentulous area adjacent to the defect, from which the bone is pushed into contact with the root surface without fracturing the bone at its base. The bone from extraoral sites are obtained from the iliac crest. The iliac autograft, the use of fresh or preserved iliac cancellous marrow bone, has been extensively investigated. The technique has proved successful in bony defects with various numbers of holes, bifurcations, and supracrest. However, there is several problems with the use of iliac autografts, such as post-operative infection, exfoliation, sequestration, varying rates of healing, root resorption, rapid recurrence of the defect, increased patient expense, and difficulty in procuring donor material. For that, this technique is not used. The allografts. The allograft is bone taken from another person of the same species. Attempts have been made to suppress the antigenic potential of allografts and xenografts by radiation, freezing, or chemical treatment. Bone allografts are commercially available from tissue banks, obtained from cortical bone within 12 hours of the death of the donor. Defatted, cut into pieces, washed in absolute alcohol, deep frozen. The material may then be demineralized, subsequently ground to a particle size of 250 to 750 millimeters and freeze-dried. Finally, it is vacuum sealed in glass vials. Numerous steps was taken to eliminate the viral infectivity. These include exclusion of the donor from high-risk group, various tests in the cadaver to exclude any type of infection or malignant diseases. The material is treated with chemical agents or strong acids to effectively inactivate the virus, if still present. We have to notice that the risk of HIV infection is 1 in 1 million to 8 million and is therefore highly remote. Undecalcified freeze-dried bone allograft is considered an osteoconductive graft material. Bone fill exceeding 50% to 67% was reported of the defects filled with freeze-dried bone allografts, and 78% of the defects filled with FDBA plus autogenous bone. The decalcified freeze-dried bone allograft is considered osteoinductive and is known as DFDBA. It has the same osteogenic potential as autogenous materials and more osteogenic potential than freeze-dried bone allograft or FDBA, and therefore preferred. The cortical DFDBA resulted in more desirable bone regeneration than the cancellous DFDBA, 2.4 mm versus 1.38 mm of bone fill. Demineralization in cold diluted hydrochloric acid exposes the component of bone matrix closely associated with collagen fibers that have been termed bone morphogenic proteins. For that, the bone graft is osteoinductive. Histological study in humans showed new attachment and periodontal regeneration in defects grafted in DFDBA. In periodontal defects, DFDBA resulted in significant probing pocket depth reduction, attachment level gain, and osseous regeneration. The combination of DFDBA and guided tissue regeneration have proven very successful, and we'll see this in limitations of the use of DFDBA include the possible remote potential of disease transfer from the cadaver. Notice a bone inductive protein isolated from extracellular matrix of human bones termed osteogenin has been tested in human periodontal defects and seems to enhance osseous regeneration. The xenograft, which is a bone graft taken from other species, is not used widely those days because of the possibility of disease transfer. From those xenografts, we have the calf bone bow plant, which is treated by detergent, extraction, sterilized, and freeze-dried, has been used for the treatment of osseous defects. The kyle bone, which is a calf or ox bone, denatured with 20% hydrogen peroxide, dried with acetone, and sterilized with ethylene oxide. The anorganic bone is an ox bone from which the organic material has been extracted by means of ethylene diamine. It is then sterilized by autoclaving. As I said, these materials have been tried and discarded for various reasons that are mentioned only for historical perspective. Currently, an anorganic bovine bone marketed as BioOs from OsteoHealth has been successfully used for periodontal defects and implant surgery. It is osteoconductive, porous bone mineral matrix from bovine cancellous or cortical bone. The organic component of the bone are removed by the trabecular architecture and porosity. The physical features permit clot stabilization and revascularization to allow for migration of osteoblasts leading to osteogenesis. BioOs is biocompatible with the adjacent tissues, eliciting no systemic immune response. Periodontally, BioOs has been used as a graft material covered with a resorbable membrane, BioGuide. BioGuide from OsteoHealth also is a bilayer procaine-derived collagen. Recently, Yukna and co-workers have used BioOs in combination with a cell-binding polypeptide that is a synthetic clone of 15 amino acid sequence of type 1 collagen marked as PepGen 15 from dense play ceramic. This combination enhanced the bone regenerative results of the matrix alone in periodontal defects. The lecture is to be continued.